Jimmy, welcome to the podcast. I'm super excited to work with you today. Thank you so much for being here. For people who aren't familiar with you and your practice and even this company we're going to talk a little bit about today called Inkwell, would you mind filling them in a little bit about who you are and all the amazing things you've got going on?
Well, Dan, first of all, thanks for having me. I'm really excited to talk about this. It's something very near and dear to me. It's been a passion play of ours. Um, a little bit about me. I guess it's important to frame things. I'm an orthopedic surgeon. I focus entirely on hips and knees. I'm in private practice, now boutique practice. And the hips and knees practice comes from a background of both sports medicine and joint replacement training. So I have two fellowships. I also have a background as an engineer and industrial designer. So there's been quite a few products that we've kind of been involved with or brought to market, and this kind of leverages a lot of that history. So my practice now is entirely hips and knees. Oh no, by the way, I also work I have an honorary professorship as a physical therapist as well, by the way.
That's
Uh,
awesome.
but we do quite a bit in the functional medicine and performance focused stuff, and I know that you do as well. So I think this is kind of a good fit in terms of just conversation. So thank you for having me on.
Yeah, absolutely. And as you mentioned, you've got a very diverse background. You mentioned honorary physical therapy, you mentioned engineering, you mentioned surgeon and boutique practice, and so many different things. And I think all of them kind of blend together and create this kind of unique situation that we see getting a lot of attention and just trendy right now is this concept of, hey, maybe the way we've always done things in medicine is not good enough, and maybe we can innovate, we can evolve, and we can enhance our tactics and strategies to produce better outcomes for our patients. And our patients, if they're seeing an orthopedic surgeon, regardless of what procedure they're having, upper extremity, lower extremity, we always sort of expect a post-op effusion to occur, right? The surgery is trauma to the localized tissues. The body doesn't necessarily understand that, hey, this is a good trauma. This is beneficial. It's going to help us. It inflames. It causes fluid to build up. It backs up into the periphery. And one of the biggest differentiators in patients that I've worked with who get phenomenal outcomes versus maybe lackluster outcomes is the ability to get that effusion managed very, very quickly post-operatively. I'd love to start by just getting your thoughts on that post-op effusion, especially with some of those low extremity pathologies that you've seen that way in your practice. You mentioned hips, you mentioned knees. I mean, some of the different knees I've seen, people's entire calf and lower leg puffs up because it just backs up so much and the system can't handle it. Have you seen similar things? And if so, what kind of things have you typically prescribed to your patients in order to manage that?
Well, there's a lot to unpack there because it's like there's so much there, right? So, there's effusions, there's edema, there's lymphedema, there's just generalized inflammation. All of those things have different pathophysiologies behind them. The reality is that they all adversely affect your outcomes. I think that's what you're seeing, right? So, every single one, anything that can cause increased inflammation causes a delay in recovery and it causes a bigger hurdle for the patient to deal with after surgery. A very dear friend of mine, Andrew Wickline, has been very, very front and foremost in this entire process. He's published a book called Less Pain, Less Swelling after surgery. And he's really come just directly against the traditional way of recovering from knee and hip surgery. But there are others that are following that same footsteps. Like we've recently heard about the HSS a quiet knee protocol. We've heard about others that are delaying physical therapy intervention because what we do know is very specific. As you said, you know, surgery is guided trauma. It is specific injury. And so if you think about that, you have really a bimodal distribution in terms of your inflammation. You have the surgical inflammation that takes a while to die back down, and then once you're kind of at flat, you have your increased activity inflammation. And what we have a system where we're so deathly afraid of stiffness, of immobility, of all of those things that come with surgery, like blood clots and pneumonias and infections and urinary retention and mental status. And all that stuff comes from early activity, right? You want early activity to avoid those things. Um, we're in the era now where we're not causing so much what's known as iatrogenic injury, or you're not doing so much intervention. We're in an era now where we're doing less anesthesia, minimally invasive techniques, significantly shortened surgical times, and we know that significantly shortened hospital stays, if there's a hospital stay at all. That's the era that we live in right now. So all of those things that we worried about in the 1990s, trying to keep patients alive, those things are almost pretty adequately taken care of. Now we're looking for patient experience stuff, right? So I'm sorry that we're talking about the whole frame of reference, but you asked a question. Your question was, what do I prescribe or what do I do for those patients? And the answer is everything. There's so much stuff to do for this. There's everything from multimodal pain control all the way to cryotherapy, all the way to pre-surgical treatment, prehab. I mean, every single one of these things additively makes better to have. You know, not one thing does everything, but you add a few nice to haves, you've got a great to have. And it's really changing what we're doing. So, you know, the technique or the technology that we're talking about here is just one of those things that allows us to measure those outcomes. That's all.
Yeah. Yeah, I think that's huge because as you alluded to, post-op effusion is complicated. And just when you think you've got it figured out, you're going to run into a patient that you throw the entire kitchen sink at and nothing sticks, right? They're icing, they're doing, stim, they're doing ankle pumps, they're elevating, they're doing compression, they're doing everything that you normally prescribing. It's not getting better for some reason. And ultimately, I think that that post-op effusion management has to be individualized and unique to the patient, right? Everything that we prescribe that way, we almost have to look the same way we would prescribe a medication, right? There's a dosage to it. So I might tell people, hey, you're going to start icing for 10 to 15 minutes, cryotherapy, 10 to 15 minutes every 2 hours that you're awake. So maybe 6 to 8 times a day, depending on how long you're up for, we're hitting it with that. If that's not enough, maybe we go a little bit more. But I've had other patients where their skin is a little bit sensitive and we actually start to see an ice burn develop. So then we actually back that off and we up the dose of other things. Hey, we need more time with the legs elevated. We need more ankle pumps. We need more of all these other things that we give to reduce that post-operative effusion. But ultimately, all of that is dependent on having someone to assess it and keep eyes on it. And now more than ever, that's becoming increasingly difficult. Here in North Carolina, where I practice, there was a patient a little over 6 weeks ago that I saw in a clinic that I was filling in at for a friend. And that patient was only able to actively lift their arm to 90 degrees on eval. We were authorized 4 visits, even though they need to lift their arm overhead for day-to-day life. We only have 4 visits to figure that out, right?
You were
So in the
authorized by the insurance company or
insurance company. So with more of these hurdles coming up, now more than ever, we need a way to assess these post-operative effusion metrics objectively without the presence of someone physically in person, because now more than ever, that's becoming increasingly difficult to get from a PT standpoint. Most surgeons are not able to follow up with their patients, 2 times a week in person, unfortunately. And a lot of patients are just in these situations where they can't necessarily afford to pay out of pocket for the services that they need. So I think having something like, in this case, Inkwell, something that might be a little bit more cost effective and affordable, but allows that monitoring and assessment of the objective data of a knee or a foot and ankle or whatever you had operated on, I think that solves a huge problem for us. And that's one of the many reasons I've been so excited about it, so excited every time I talk with John. And obviously, part of the reason we're here today is to dive into that more. So I'd love to hear more about your role with the company, what it is, and kind of where you see that fitting in to this post-op effusion management puzzle that we're discussing.
Okay, great. So let's just talk about it because we've been talking about how this fits in. You and I both know that. I mean, you just touched a very important point, is that you've got someone authorized for 4 visits by their payer, the insurance company, to do seemingly a very large mountain of exercise with 4 visits. I mean, that's just kind of silly, right? But we're in a place right now of, we're working from a place of scarcity. Doctors are burnt out. We don't have enough time with the patient. We have way too many patients. We have dwindling reimbursement for all that stuff. And no matter how cool the technology is, it's got to make financial sense, right? So we'll talk about that a little bit. I want to show your audience what the technology is first, so we're not just kind of waving our hands. So I'm going to share this screen right here. This is what Inkwell is. What it is, can you see this?
Yep.
Do you see my cursor on it?
Yep.
Okay, so this is a temporary tattoo that goes on the knee in this case, but we have other products that we're creating. And what it is optical sensors. So what we use is a cell phone camera, all the way down to legacy iPhone cameras, all the way to legacy Android cameras. And what you do is you can, I'm going to share another screen with you. You can, like collecting a check, you can take pictures of your knee. And what we've done is we've been able to use this technology to extrapolate a volumetric change, range of motion, swelling, growth, and temperature, okay, with that little temperature sensor, and self-reported patient pain. It's really just an app with a lot of optical anchor points. So what this is a method of patients self-reporting what they're doing in a very objective way without having to say, oh, sort of, it kind of looks like this kind of stuff. We can say exactly what it is, and we can measure that, and we can graph it on a daily basis. And the patient compliance rates are very, very high. Now, as you can imagine, temporary tattoos don't cost anything. They're very, very low cost. It's very different than putting electronic sensors onto the knee, which are very high cost, especially in our post-COVID supply chain restrictions that we've got, right? So, those got very expensive very quickly, whereas what we're doing is much, much, much cheaper and honestly more accurate. And so now we've got something that seems to work really well. It's driven by patient volume and is driven by patient interest. Now, my role in the company is I'm one of the founding members. There's three of us as founders. As myself, it's Dr. Michael Gross from Halifax, Canada, and then also John Matthews, our CEO from London, Ontario. And the three of us all have various input into the company. But I'm going to show you what's going to make a lot of sense for our audience. Okay, the thing that I'm most proud of is this very specific piece of innovation. And I'm just going to show you something that most of your audience is probably familiar with. So this is kind of the inspiration for that. So this is a picture of Avatar. By the way, this movie came out and this technology was out in 2009. Okay, so it's not new technology. But what they are, you can see a significant amount of similarity between the technology that I just showed you in the knee and what's going on in the facial stuff here. So what those dots are is those are called reticles. They're an optical anchor point for a camera, in this case, to create a CGI for in this case, a movie Avatar. And this was groundbreaking at the time. And this could create very cool animations where the actors can actually act through the faces of the cartoons. But in our case, instead of making live video, what we did is we created algorithms that extrapolated volumetric change and position, okay, using the exact same technology, okay? Now, our original patent was for temperature-sensitive ink, but we didn't realize, and this is kind of funny, we didn't realize that temperature-sensitive ink was also carcinogenic, so we don't do that anymore. But we do have a little sticker that we put on for the temperature. And so what this does is it creates what's known as a computer vision model. That means that it's taking something in real space, in this case, your knee, but we have other applications for other body parts. And it's creating a mesh model of it in three-dimensional space in the computer. And that's how the volumetric change is, and that's how the position sense is extrapolated, is because we are digitizing the knee in space. Now, for facial recognition software, like opening up your iPhone or going through Clear at the airport, that's it's different because you have eyes, you have nose, you have ears, you have mouth, you have things that you can proportionally anchor to. But if you're going to a rather nebulous area like an elbow or a knee, it takes a tremendous amount of processing power to be able to figure that out with a change in shadowing and light source. So putting optical anchors becomes even more important because we're not relying on very heavy liftings, computer-wise, to get the same information out of it. And this is all self-calibrating to the silhouette too. So once it fades, a patient can put one on upside down and backwards, and it'll still recalibrate and it'll continue to work. So usually a tattoo lasts about 2 weeks, and then they can put it back on. By the way, we've demonstrated that a 6-year-old can do this. It's like a Cracker Jack tattoo. It's pretty simple. So it's very cool. So the reason I wanted to talk about all that stuff is because you're talking about how do we essentially force multiply what we do, right? We are limited in what we've got. Our bandwidth is limited. Our patients' needs are growing, and expectations are growing too. And the resources we've got are less. So what we've got to do is we've got to leverage what we have in a way that actually delivers that. Okay. And so now what we've got is we've got a way to measure it all, which is really important, but there's something else too. And I know that you've done this as a physical therapist. You realize this is that a lot of surgeons will throw a patient in front of you before the patient's actually ready to do any exercise because the doctor just wants eyes on the patient. That's babysitting. That's not actually therapy. And we've been able to demonstrate very clearly that early physical therapy during your initial inflammatory cascade, probably not very helpful, if not harmful for the patient's experience. We've been able to show that now, and there's a growing body of evidence that's starting to show that too, because we're always focused on endpoint function. We're always focused on decreased opioid use, decreased manipulations or anesthesia, faster recovery, better range of motion endpoint, better overall strength. We're looking for all of that stuff. And so much of that falls outside of that 1 hour plus or minus time frame of surgery, and all of these things like physical therapy and your post-operative recovery pathways and all this stuff are mission critical, not just to the patient experience, but to their endpoint outcome. And we're starting to become now predictive with this. So that's kind of what we're talking about.
Yeah, and you brought up so many amazing points there. Obviously, we started this topic, this conversation around effusion, but you also mentioned the temperature element, which I think is so often overlooked, right? Knock on wood, we've only had one patient who had to go back to his doctor because of an infection in his knee. I want to keep it that way. Regardless, if you're not checking and assessing for signs of infection regularly, then you're going to miss it. And the sooner you catch that, the easier it is, right? That could be the difference between a washout versus, hey, we just need some oral antibiotics or something like that. We don't actually have to go in a second time because we caught it quick enough, right? So catching these things quickly, as you mentioned, having those eyes on the patient every day, whether or not they're in person or just literally taking a picture with their phone, is absolutely essential. The other element that I love about this, and you kind of alluded to it, is patients often struggle to describe what they're feeling post-operatively. They've never felt these sensations before. They're trying to come up with any analogy in their brain that makes sense, but they've got nothing because they've never been here before. So instead of putting more stress on them because they're already stressed enough, right? They just had a major procedure. Things hurt. They're not sleeping good. Everything is just going haywire right now. And now you're expecting them to clearly articulate everything that you need. You're putting pressure back on them. If anything, I want, as a clinician, to take pressure off the patient. I want to tell them, hey, look, it's okay. We've got what we need. We know where we're going. Let's restore some confidence in the plan without putting more than we need to on them, right? So by doing this daily check-in with the inkwell that way, we get the data that we need. We don't have to ask the patient, oh, how does it feel? Has it felt warm? Has it, been swollen? We already know all this stuff. We don't have to ask them. We save time. We become more efficient. And again, we shift load off the patient. We shift pressure off the patient, which, as you alluded to, sometimes less is more. As you mentioned, sometimes these early post-op PT interventions do more harm than good. And it's one of those things that I know is highly, highly controversial and debated. But as someone who saw at least 50 ACLs day one post-op, about half of them crushed it and did great. And the other half there's tears, there's crying, things hurt. And it's like, I wonder a lot. Could we have waited just one more day? Could we have given it one more day before we pushed him in? Maybe, maybe not. Hindsight's always 2020. But overall, if this improves the patient experience, not just the light at the end of the tunnel, because as you mentioned, we've been so focused on that, but if it makes those first couple weeks maybe a little less hellish for the patient, then we need to lock in on that and go all in on that. Because as you mentioned, I feel like we've sort of missed the boat on that to a certain extent.
I think it's more than just the patient experience also, though. I think it's your experience too, as a
Right,
provider. My experience as a
right.
physician, your experience as a PT. I mean, you get to focus on the end. You just said you got authorized for 4 visits for that shoulder. Well, what
Yep,
happens if you get 15 visits for the knee? Okay. You want those 15 visits to be where you're actually getting performance improvements, not
right.
in the beginning where you're just kind of saying it's okay, it's okay, it's okay. You really want to do your job. And that's what's most exciting is when you see patients getting back to what they need to do. So we're working within the system itself to try to make the most out of what they're given. If that makes sense, right? And one perfect example is just the number of visits authorized. That's a perfect example. A greater example is we're decreasing the number of patient visits directly because I didn't tell you about the app is that what we did is we tabulate. We have a graphic that shows you every day when you check in exactly where you fall on that graph, and that's done with a meta-analysis of many studies that for each particular event. So whether it's meniscal surgery or partial knee replacement or total knee replacement or anything else that's there, we actually have it mapped out. So it looks like there's like a bar that goes around. And if your dot is in there, the patient immediately knows within a minute that they're okay. That amount to say they're on track is really good, or I'm better than average, or I'm worse than average. And if they're far worse than average, our system will ding the doctor or the PA to let them know, hey, they're falling off the curve. And going back to that infection thing, we've been able to predict infections weeks before they might show up normally. We've also been able to predict manipulations under anesthesia almost a month before they're required because you can see the trajectory. So we believe we'll be able to do the same thing for DVT or blood clots, but we just haven't seen enough of them. And right now we've got thousands in our database, and that's growing exponentially as more doctors and more patients are doing this. So all of this stuff is clinically directly relevant, and we know that we're going to be improving patient outcomes because of the overall experience improvement, patients, providers, and post-operative care providers as well.
Have you seen any correlations on those long-term outcomes and anything that preceded them, whether that be surgically or from a therapeutic standpoint, whether that's surgically, the approach used or tourniquet time in the lower extremity, or therapeutically, is it, how long the sessions are, or how much pressure is applied, or how much manual therapy versus self-administered exercise differentiates? Is there any kind of correlation between those elements that are somewhat controllable by the clinician and that outcome that you were mentioning that you see from the inkwell side of things?
So many of those things are directly correlated. Everything you just described is reliable. It is important. And what's interesting is that it seems to be very provider specific. Some providers get more mileage out of changing a small amount of their practice. Other providers get more mileage of changing just a few smaller things even. Like I said, it's a bunch of small things added up. But what's interesting about this is that you wouldn't know if you didn't look. Like you just wouldn't know. And
Right.
so this is one of the reasons why we're so collaborative with Andrew Wickline, because he spent his entire career figuring out all of these things to minimize his swelling, minimize edema, maximize outcomes. And it's so many little things that go into this. And you're right. It could be tourniquetless surgery. It could be a quad sparing technique. It could be utilization of post-operative tranexamic acid. It could be pre-operatively cooling the leg or post-operative cryotherapy. It could be a question of timed physical therapy, whether it's early, midway, or late utilization. It could be home exercises. It could be, edema garments. It could be anything. There's so many things there that can additively make a difference. And the problem is that unless you know the provider and exactly what they're doing, you don't know what's exactly going to make a huge difference in their practice until you try. But we have a way to measure it. So we've been able to, an interesting case series. By the way, we've only been in business. We did our launch at the Hip and Knee Society, the AAHKS meeting, not this year, but last year, 2024. So we are just about a year and a half old in terms of a company. We're very young, okay? And during that time frame, we've been able to have surgeons that have onboarded to us that thought they were good, looked at the data, looked at what they might be able to improve, tried one, two, maybe even three smaller things, and became exponentially better at what they were doing given our metrics. And they're just like, I didn't realize how bad I was until I did this, and now I'm so much better. They didn't have to do much. It's kind of crazy what goes into this, right? So, I think a lot of it depends on your start point. A lot of it depends on your appetite for change. But if you don't look, you don't know at all. And the point is we have a really reliable way that you can look. Okay, and that I think is super, super important. I wanted to talk about something that you mentioned before. I want to go back to your four authorized visits. Okay, so this company was designed around a very compelling use case. We wanted to do better for our patients. We wanted to do better as physicians and care providers. And we wanted to do better within a system that was dwindling resources. And I have to credit John Matthews, our CEO, for this. His major innovation was before validating anything we've got, before doing any of this stuff, we found a way to make it financially viable. And I think that's a really important thing. So, by the way, we're going into other markets. We're about to launch in the UK as well, and we have a collaboration with their government on their NHS. So, because of how much this could do for them, but in our system in the United States, we have a payer system where there's insurances, Medicare, Medicaid, all this other stuff. And what we've been able to do is we've been able to drive to physical therapy practices or doctor practices revenue for using this, and that's a really important thing. So this is something that directly increases income to the facility, which eventually will lighten up bandwidth burden for our providers. We've been able to show significant increase, and we have hovering around 82, 83% compliance for billing. We're not talking about compliance for use. We're talking about how many patients can use this and you can get reimbursed as a provider. That's a super important thing, because now whatever minor extra work that you have, and this is really no extra work, but whatever you're doing to change your infrastructure is probably a better way to put it. You're getting direct monetary gain from it, which means it can be adopted readily. And if it's going to be adopted readily, it's very useful to the patient, it's very useful to the provider, and it's very useful to other providers. But the data cloud that we're going to get from this is going to be enormous.
Absolutely. And as you mentioned, this is all data that wasn't previously available to providers because there was no way to get this many data points that regularly, that consistently as you are. And it creates this scenario where now we're actually able to almost look at each individual patient like their own case study. They always were, but now N equals 1 just became millions of times more effective because we're getting data daily. We don't have to ask them. We can still ask them, but we know what happened the day after they left our office because we can pull up and see the data. We don't have to sit around and wonder or wait for them to report 3 days later and wonder if they can remember back that far, because I can't even remember what breakfast was yesterday myself, right? This simplifies that entire process, 1. And 2, you brought up the piece that so many clinicians do not want to talk about, the finances. But this is a business. Whether you like it or not, the healthcare system in the US in 2026 is a business. And in order to keep the lights on, in order to keep helping people, you have to bring revenue in. If you bring revenue in, you can expand your operations, you can buy all the fancy, shiny new toys, everything you want. But ultimately, I've found in my experience, the best way to bring revenue and market and grow is to just do really freaking good by the person in front of you. Get them a phenomenal outcome. Become the person, the guy that when someone else asks them, hey, I injured my knee, I injured my hip, my foot, who do I go to? They immediately think of you, call you, and send them your way. And this is one of those tools that I would personally use in my own arsenal to be that guy. Because 1, Not everyone else has this right now. I think in 5 years, this will be the norm. This will be the standard. I think that's where we're heading. But I like to be ahead of the curve, which is why I'm so thankful that we got connected back in Vegas back in September, because I love to learn about new things and I love to bring light to them early on and kind of predict the future. You know, one of our claims to fame about 3-4 years ago, we did a podcast on palm cooling. And now every time I open Instagram, palm cooling is popping up, right? It's amazing to see what this stuff is going to become in the future, one. And two, with this shift in healthcare, especially on the therapeutic side, away from in-person sessions and visits and more towards a remote model, because we're finding, hey, some of these patients, they're pretty smart and they don't necessarily need a physical therapist or an assistant or a tech present every single session to do the same exercise that they've done for the last 5 sessions. They figured out how to do a quad set. They figured out how to do a heel slide. Like, they don't necessarily need you physically there, but they still need access to your knowledge. They need access to your insights. They need access to your brain telling them when to progress, what that progression looks like, how much, how little. And ultimately, if you can do that without physically being right there every single day, you've just established your effects. You've just increased your effect size significantly, because you're now able to have such a positive effect on more patients with less actual in-clinic time.
Well, and I want to make it very clear. I mean, you can structure this any way you want to. One way is exactly what you're talking about. You can scale yourself much more if you're not in person all the time. Another way is what we use in our practice. It's truly just parallel. We still use physical therapy classically after surgery at a certain time frame. Now, I've adjusted my time frame because of the data that we have, but we're also doing the remote monitoring as well. It's not remote monitoring, it's remote therapeutics. So we actually have a remote therapist that works with them on the inkwell stuff. So they're basically doing homework in between the sessions. And I can tell you right now, it's very obvious that they're getting better faster, and they're achieving a higher level of function by having that. So if you have a practice, a physical therapy practice, where you're seeing all the patients at a certain point in time, this in no way would inhibit or interfere with your in-person visits at all. And I know that that's a fear too, because what this specifically does is it has 5 remote patient therapeutics codes that are not part of the global period and are not part of your in-person physical therapy codes. That's really important for billing, because if you have a practice, you don't want to cannibalize one thing for another. This is an extra resource, and that's the nice thing about it. It's truly an additional resource.
Absolutely. And as you mentioned, you can run them adjunct or you can run them separate, which is absolutely incredible that way. Now, for the population that, you mentioned, like 80 to 90% of this is getting covered by insurance, which is great. But for that population, there was an individual I worked with who actually had a shoulder surgery and he was uninsured. And that was what we were working with that way. What does this run financially for the patient like that? Because I know they saw our physical therapy bills at about $95 a session, but I'd imagine this would be actually quite more cost effective than that for them.
Oh yeah, significantly more cost effective than that. I mean, this is I don't know the exact numbers. I think it's different from market to market. I was just talking finances in our market, and what I can tell you is it's probably a 10 to 20 fold decrease from what you just said for time frame. The way this bills is it bills on basically 2 calendar month period is what it is. So it's somewhere around the 6 to 7 week mark is where you can end up getting billed maximally for this, and you can go out to 3 months if you want to. And this is also for other things too. You also have to remember this could be for a knee sprain that you're seeing physical therapy for anyway. And your therapy, you might get authorized for 2 visits with a therapist for a knee sprain. Well, this vastly increases what you can do. And, we're only talking knees right now, but we have an ankle product coming out. We have a hip product coming out. We have a site non-specific product that we could follow swelling and temperature on pretty much any body part that's out there. So there's quite a bit of innovation that we're doing. We think we could do things on abdominal surgery or chest surgery. We could do things on spine pretty simply with this. And then we also have innovation and patent portfolio around garments as well. So there's quite a bit that you could do in the exercise and sports optimization section as well. So, we have our eyes on a lot of things right now because the technology is so compelling and so universally applicable.
How, what is the process like you mentioned about getting the temporary tattoo? Is that something that's done like one day preoperatively or in the OR before the surgery is performed? Or how does that fit in to this picture if it's an operative patient or versus if it's a non-op patient, like you just mentioned that way? Is that something like they just get done at an ortho office or a therapy office and then the monitoring would begin from there?
Yes to every single thing you just mentioned. Okay. So the way I'm used it in my practice originally is I just had my PA place it at the very end of the surgery over the bandage, like you saw in that picture. And then they just start taking it from there. I started having it applied by the patient about 2 weeks preoperatively, so they can start a prehab routine that we started implementing, and that's a remote patient prehab. And a lot of authorizations won't cover prehab, so now we're able to administer prehab for a patient before their surgery, and then after the surgery they can continue to monitor. And it gives us a baseline also. It can be done in physical therapy office directly or in a provider office directly, and that is a billable visit for that if you want. Or the patient can just start remotely on their own time whenever they feel like it, because it really does. It takes 30 seconds to put this thing on, and it is almost foolproof. And our staff, our team at our company is set up to be able to identify and help how to do that, but it's very, very seamless. So yeah, it can be done in any one of those ways. What you described is all possible.
Yeah, absolutely, which is incredible. And as you alluded to as well, that non-operative side of things, my brain was just going a million different directions with that because even just the rise, and you had mentioned temperature before, and to come back to that, a few months ago, I was at a lab at a Division I university, and they were doing thermal imaging on all of their athletes. But that thermal imaging camera cost around $30,000, and that's
Yeah.
just one camera, by the way. You're doing that one person at a time at 30K versus now you're able to get more specific insights regularly, consistently. Yes, it's joint specific, but in a way, I kind of like that better. And I don't think that we have the holy grail algorithm figured out yet of how to predict injury by any means. But I think that if we start to collect this data and we start to notice, hey, something's not right with a joint or something's different in a joint before injury occurs, then at least now we know, hey, we have to look a little bit deeper. We have to check under the hood, right? We now see that the check engine light is on, whereas before we would have just kept driving the car. Now we know, hey, let's pause a minute and assess a little bit deeper before we continue. So I think this is something, again, just thinking about the future for a second, this probably plays a much bigger role than people realize in that long-term picture and puzzle of how do we reduce the incidence of some of these things from occurring, whether that's sports injury or even just delaying the need for orthopedic intervention, right? Like, a lot of
Well,
patients, go ahead.
no, no, you're exactly right. So, I mean, what you're getting at here is the fact that care, whether it's an ATC, whether it's a physical therapist, whether it's a physician or a nurse practitioner or PA, seeing a patient, or even a patient going into an emergency room, care at its very baseline until more recently has been episodic. You show up when you can get in. That's really what it is. And what we have now is we have a method to kind of throw a flag up and say, hey, there might be something wrong now at 2 in the morning or whenever, or a day before or 7 days before you could get seen. That is a very, very, very different circumstance because and I know problems are not episodic, right? And the longer you let a problem stew and brew, the worse that problem can potentially snowball, right? And so if you can somehow match the care to the delivery of said care, or maybe the problem is the care and the delivery, now we're getting closer to actually better medicine. And that's what we're trying to do. We're trying to narrow that gap. So if we have a method that we can measure that can say, hey, it's going to bother that care provider at sometime in the middle of the afternoon, 3 days before they were supposed to be seen. That's 3 days that you get the notification before you were going to be seen. That's a big deal for the patient and for their outcomes.
Absolutely, absolutely. And the other element too is just thinking about the rise of this emphasis on joint preservation and joint longevity, and just seeing how this longevity space has blown up in recent history that way. Thinking about some of these other factors beyond just what we normally think about on the physical side of things, right? We often think about movement, we think about anatomy, but we often forget about the physiological effects, right? Like if someone is running high from a systemic inflammation standpoint, and maybe they had an ACL reconstruction 10, 15 years ago, right? What's that knee look like? What's it doing now in response to, hey, we sat on a plane for 24 hours because we just flew across the world, or hey, we ate really, really crappy and drank a lot the last 3 days because we were out late night in Miami having ourselves a good little time. What does that do to the knee? And again, things that we often haven't looked at, haven't thought about, but now it's easier than ever to do this. And again, there's such a growing interest in this longevity space and joint preservation, which is why I bring it up, right? This is stuff that I think people are recognizing is important. Like, hey, maybe I shouldn't go on a 3-night bender in Miami and then fly back to North Carolina and run a marathon the day afterwards, right? It's been done, but maybe we should look a little bit deeper first. And I think, again, this solves that issue amongst many others that we've discussed today so far. Jimmy, is there anything that we didn't get to discuss or anything that we missed as we've been chatting today?
I think you know the answer to most of my questions today. But yeah, there's so much stuff that we haven't talked about, but I don't know if we have time or bandwidth to talk about it in this session. Maybe it's for another time. I really think that you and I have talked a lot about what this is. I think it's an easy technology to wrap your head around. I think it's pretty obvious what it does and how it does it. And I think the compelling things is that it can be utilized in ways that we all believe that will improve patient care and our experience as providers as well. And we know that it works financially too. It's all of these things that are important. We know that this company's going to grow. We're very optimistic, if not just truly enthusiastic / excited about what this is. And I know you are too, because that's why I'm here. So thank you for having me.
Absolutely, Jimmy. And for people who want to find out more about Inkwell, more about you and your practice, where can they find you at online and that sort of thing?
So our website is inkwellhealth.com. Okay, that's the easiest place to find us. If they want to go to my personal website, it's chowhipandknee.com, all spelled out. But I would redirect everybody to the Inkwell Health sector first, because there's a lot of pretty good information there. By the way, there's also a physician portal there that the providers can log into to see how all their patients are doing, and you can see the snapshot of it. That's not available to the general public. It's just on there. so there's it's password protected, but it's there, and so we have a full database on the back end, and that's kind of a very important thing going forward too. And I know I mentioned that before, but we forget about we don't forget about it. But the pure academic side of things is important for advancement of our pathways. And if you just do something just for that, it's very hard to get it through. If you do it for altruistic means on all sides, it's almost like the ball just rolls itself. And that's where we are.
Yeah, no, you're spot on with that, Jimmy. We'll link to all of that in the description below as well. That way, if you didn't quite catch it, you can just click there and find out more about Inkwell. Reach out, get in touch with the team, get a consult call going, and learn more about how you can use this to enhance the outcomes of your patients and your clinic overall. Jimmy, this has been incredible. Thank you so much for your time.
And thank you so much. I really appreciate you having me.